before imaging any structure, it's important to have a basic understanding of transducer selection and image optimization. For most musculoskeletal ultrasound studies, you'll be using a linear transducer such as this one. And as you can see, it has a linear footprint. The second is you would like to use the highest frequency transducer available for that study. So this is a 17 megahertz linear transducer. Depending on the system that you may have other types of linear transducers. This is a 12 megahertz linear transducer. And you can see that this has a larger footprint. So depending on what you're imaging, you may want to use something like this. What you want to avoid is using a curved transducer such as this 5 megahertz curved transducer, and this is generally used for the abdomen or for deeper structures, so you may need to use it for something deeper such as in the hip. Next, when you're doing any ultrasound imaging examination, you want to have adequate gel to achieve best contact between the transducer and the skin. And then you might want to make use of the machine presets or these predetermined settings that will optimize your image. So in this case, this is set for the general musculoskeletal examination, but for this example, I will select the superficial musculoskeletal presetting. You can see that over here. Okay. Next, you want to make sure that you have your depth optimized for the structures being imaged. So in this case, you would want to make sure to decrease your depth to really center on the structures being imaged. Next, you want to make sure that you don't have too much gain. As you can see, when there's too much gain, you lose delineation of the structures being imaged and you lose definition. So you want to turn down the gain. Most machines come with a button that will optimize the gain and other settings for you. And then you can fine-tune it to your liking. You also want to make sure that you are focused on the structures being imaged. So the machine has a focus or focal zone, and you want to bring that up to the structures being imaged. So in this case, I'm moving the focal zone up. You can see the image improving as we're moving it up towards this tendon that I'm imaging. Now, as for the screen orientation, most transducers have a marker. You can see the marker on this right here. And the marker should be oriented towards the patient's head or cranially in a 12 o'clock position or 90 degrees to the patient's right. On the screen, this marker corresponds to a marker predetermined or set by the manufacturer. So when we are looking at the patient's right, when the marker is at 9 o'clock, we are looking on the left side of the screen. And all images obtained this way will have this be the right side of the screen, or the left side of the patient. Anything on this part is anterior or closest to the transducer, which you need to remember when you're scanning from behind. And anything on this part of the screen is deep to the transducer. When the marker is at 12 o'clock, then anything on this part of the screen is more superior or cranial, and anything on this side of the screen is inferior or caudal. This will still be anything closest to the transducer, and this will be further or deeper from the transducer. When you're labeling your images, it is best to use long axis and short axis as your designation. And when you say that, you're referring to the structures being imaged and not the patient. So if you're looking at a long axis view of a tendon, you will see that the tendon fibers are oriented along the screen or along the image. I'll just change the depth here. Okay, and then in short axis, you're looking at a cross section or transverse image through that tendon, which is right here. Another example is looking at the short axis through a muscle. So you see the cross section of the muscle fibers and the fascia versus the long axis where you see that pennate structure of the muscle. And you see the fibers going alongside the image. We will begin with scanning the anterior portion of the shoulder to look at the biceps tendon and subscapularis tendons. Just want to point out again, we're using a linear transducer, in this case a 12 megahertz. Okay, I'm using the general musculoskeletal preset. And again with the marker at 9 o'clock. Now we want to scan with the patient positioned with their palm up. And typically we'll have them sitting on a stool or a swivel chair. Or you can have it at a high chair with you standing up. Okay, we'll put the transducer transverse. And here you'll see the biceps tendon, which is an ovoid echogenic structure, in the bicipital groove. Okay, and some of the landmarks here, we are looking at the lesser tuberosity and the greater tuberosity and the transverse humeral ligament. Now, if the biceps tendon does not look hyperechoic, you want to make sure that you're orienting your transducer perpendicular to the fibers to eliminate anisotropy. You want to scan in the transverse plane to find the most proximal portion and follow it distally till you get to the myotendinous junction. So there's distal, and again there's the proximal portion, and you're in the bicipital groove, and you follow it all the way proximally. Next, you will turn on the biceps tendon. So when you turn, you want your marker to be at 12 o'clock. Okay, and when you do that, you can see the long axis view of the tendon. Okay, and again, you want to be able to scan the most proximal portion and then follow it down, slide down toward the myotendinous junction. And again, because the tendon will dive down, you want to heel toe your transducer to address anisotropy in the tendon. Here's that biceps tendon in long axis. Okay, so short axis view and long axis view. Next, we're going to look at the subscapularis tendon, which inserts on the lesser tuberosity. So we'd like to slide over to put that in the center of our screen. And a good landmark to use is the coracoid process, okay, which is right here. Here's the lesser tuberosity. And here we are looking at the subscapularis tendon. Now, much of it is diving into deeper portions here, and so we don't see it due to anisotropy. One way to bring those fibers into view is have the patient externally rotate their arm. Okay, and you can see when she does that, she is bringing the subscapularis fibers into view, and also they are now perpendicular to the beam. Now, you don't want to confuse this hypoechoic area with abnormal tendon. Here we are looking at the subscapularis muscle, and moving towards insertion, we are at the myotendinous junction, and then the subscapularis tendon. Notice the parallel echogenic collagen fibrils that are perpendicular to the beam. And if you have concern about pathology here, well, you want to make sure this is not anisotropy. You can reorient your transducer to bring that portion perpendicular to the beam. Now, this is a three-dimensional structure, so we want to be able to look at the most superior portion where many tears can be missed, and slide down to scan the entire tendon, including the inferior portion. you want to scan it in short axis. Now I want to point out, when we are talking about long axis and short axis, we are looking at the long axis of the tendon right now and not the long axis of the patient. And when we want to look at the short axis of the tendon, we are turning the transducer again with the marker now facing 12 o'clock. And now we are looking at the short axis of the tendon on the screen here. Here's the humeral head, a little bit of the hyaline cartilage you can see here, which is hypo to anechoic. And then we're looking at the tendon and the tendon bundles. Notice that you're not seeing one discrete tendon, but what looks like several tendons, because the tendon fibers do not all run parallel or are not in the same orientation. And you want to scan towards the myotendinous junction. Here we're looking at the muscle. And then you're scanning back towards the lesser tuberosity to watch all the fibers insert. So this is the short axis of the tendon. And then when we turn the transducer this way, we are looking at the long axis of the tendon, the inferior and then the superior portion. Okay, moving on to the supraspinatus or supraspinatus tendon. Typically, there's several ways to do it, but I prefer to scan with the patient facing away from me and with the screen in view so I can see what I'm doing. Okay, now, if you palpate the back of the patient, you will feel the scapular spine, which runs across. If you don't know where it is, we can look for it on the screen. I'll show you later. But the supraspinatus sits above the scapular spine and comes down and inserts on the greater tuberosity. So I prefer to scan with the patient facing away from me so that I can put the transducer comfortably to look at that tendon. Second is you can have several positions for your patient. You can have them place their arm behind their back, okay, or have their arm in their back pocket. Ironically, patients with supraspinatus pathology can't be in this position, so you can actually have them put their hand in their front pocket and keep their elbow back also. But since we have a nice healthy patient, we'll have her put her arm behind her back. Okay. Now again, reminding you that the fibers run in this axis. We want the marker of the transducer up. Okay, and here we are getting the what they call the bird's beak view of the supraspinatus tendon. I'm going to adjust and decrease the depth. Okay, make sure that the focus is on the structure we are imaging, which is the supraspinatus tendon. If you want to, you can adjust the gain. You don't want to have too much gain. Okay, here we are looking at the humeral head. If you look closely here, you can see the hyaline cartilage. You see that the humeral head surface is smooth, the cortical surface. Here we are looking at the greater tuberosity. And here we are looking at the supraspinatus tendon as it is coming around and inserting on the greater tuberosity. Okay. Notice the parallel echogenic lines in the tendon. And again, you will want to scan all the way anterior until you hit the biceps tendon and scan as far back as you can, and noting that at this point you will be including portions of the infraspinatus as they cannot be distinguished from the supraspinatus tendon. Okay. Now, the patient is placed in this position because we have a structure here, the acromion process. And when their hand is in anatomic position, in front, you can see that much of the supraspinatus tendon is tucked in underneath the acromion process. So by bringing your arm in the desired position, slowly, okay, keep going, put your arm back, slowly. Okay, then you can see that now you see more of the supraspinatus tendon as it's pulled out from underneath the acromion process. Okay. Now another thing to note is that the subacromial subdeltoid bursa, which is subdeltoid underneath the deltoid, underneath the acromion, is a potential space that sits right here, just superficial to the supraspinatus tendon. So when there is no pathology, we will not see this bursa, but as you can imagine, when it is distended with fluid, we will see a hypo to anechoic structure in between the deltoid and the supraspinatus tendon. And another thing we can do is we can check for impingement, because impingement occurs in this small space here between or underneath the acromion process. You can have the patient extend their arm and place their thumb down, okay? And we can have them elevate and lower their arm and see the motion of the tendon. You can go faster. Underneath the acromion. So here it is, the tendon completely under the acromion, which is normal, okay? And then you can see, keep going down, what happens when they lower their arm and you see more of the tendon. So with impingement, this will catch and not be able to slide completely under the acromion. Let's just raise it a few more times. Here again, we see it completely going under the acromion. Okay, and go back out. And there we see it again sliding out from underneath the acromion. Okay, so this is how we would check for impingement. All right, moving along to the infraspinatus. Just want to again point out the bony landmarks. Now the infraspinatus is infra to the scapular spine. So here on the screen we see this is the scapular spine. Remember now the orientation with your marker facing at 12 o'clock. Anything on this side of the screen is more superior, and anything on this side of the screen is more inferior. So if we are superior to the spine, we are looking at the supraspinatus muscle. If we are inferior to the spine on this side of the screen, we are looking at the infraspinatus muscle. I'm just going to adjust my depth so you can see most of the scapula here. So here's the scapular spine. Here is the scapula. And here's the infraspinatus and teres muscle. Swinging up. Now we are superior or cranial to the spine. We are looking at the supraspinatus muscle with the tendon forming. Now we can't trace this tendon all the way out to the insertion because of the acromion. But for the infra, we can sit here and we can slide the transducer towards its insertion. And you can see on the screen that the muscle fibers will converge together, both the infra and the teres, which are inseparable on this scan. We can see them converging together to form the tendon as it goes towards its insertion. And here is the humeral head. Again, looking at the hyaline cartilage on the humeral head, we have a nice smooth surface. I'm going to adjust my depth now. And I'm going to show you how I'm going to slide the transducer towards the insertion. I'm going to follow the tendons, and when I isolate those tendons, I will again turn with the transducer 90 degrees. Now the marker is at the 9 o'clock position, and I can follow the infraspinatus towards its insertion on the greater tuberosity. I'm going to adjust my depth. And here you can see the parallel echogenic lines, which represent the collagen fibrils of the infraspinatus tendon. And you can see here's the myotendinous junction, the hypoechoic muscle, the tendon which is hyperechoic, and the tendon coming in towards its insertion. If there's anisotropy, you just reorient the transducer to bring the tendon fibers perpendicular to the beam. The subacromial subdeltoid bursa sits on top of this, and it's a potential space, so we don't see it here. Now, anytime you image the tendons in long axis, you want to also image them in short axis. So we just turn 90 degrees from where we were. The transducer is to the patient's right. The marker is to the patient's right. And then we can look at the humeral head, the cartilage, and the rotator cuff. Okay, and then the deltoid is on top, and the subacromial subdeltoid bursa is in between. Now, just to show you here, this is the biceps tendon. So we know that lateral to that, we will be seeing the supraspinatus. And then as we slide, we don't have a clear demarcation, but we know as we go further, we will be looking at the infraspinatus and teres. So infraspinatus, supraspinatus, biceps tendon, which means this is the subscapularis. Okay, so that's the rotator cuff. Next, we can look at the glenohumeral joint. And typically, I scan that from the back. We do this in a transverse plane. Now it's a deeper structure, so we would have to we would have to adjust the depth, increase the depth now, because we're looking at a deeper structure. Okay, now since we were looking down here, we want to move the focus down to where we're imaging. See how that improves that image? Okay. Now here, we are looking at the humeral head, and here is the glenoid, right here. Here's the glenohumeral joint. This triangular structure is the glenoid labrum, okay? And right here, we are looking at the spinoglenoid notch, and that's where the suprascapular nerve sits. Occasionally, you might see a cystic structure here, because if you have a labral tear or a paralabral cyst, it can come, or a ganglion, it can come and sit in this notch and press on the suprascapular nerve. And if you look closely, you might see that honeycomb appearance that you expect to see when you're looking at a nerve. And when you're looking for a joint effusion, you will see a joint effusion in this location, posteriorly. One other thing to look at is the acromioclavicular joint. You can either palpate the bony landmarks right here and orient your transducer across the acromion and the clavicle. Now this is a more superficial structure, so again we want to adjust our depth and move our focus up. And one thing I want to point out is, so here's the clavicle, here's the acromioclavicular joint and the acromion, and it is normal for the cortical margin of the clavicle to be higher or more superior than that of the acromion. And then we have the capsule or the ligamentous union here between the clavicle and the acromion. Okay, and that's where we look at the acromioclavicular joint. Okay, when doing an elbow examination, we tend to divide it into 4 compartments. There's the anterior, the lateral, the medial, and the posterior elbow. And when you're starting out, it would be a good idea to scan all 4 compartments to get used to the scanning and to the anatomy, and later on you may target the examination depending on the presentation of your patient. So moving on to the anterior elbow, you want the arm positioned with the anterior part, or the fossa, oriented towards you and available for you to scan. And you want to be aware of a few joints, or 2 joints, that you'll be looking at in the anterior elbow. Okay. Adjusting the depth. Okay. Now you're going to look for the bony landmarks of the humeroradial joint or the radiocapitellar joint. Adjust the gain. Okay, so here you're going to see the capitellum and the squared off, characteristically squared off radial head, the neck with the annular recess. Also, there is a triangular echogenic or hyperechoic structure at the joint, which is the meniscal homologue. And another thing to know is there is a hypo to anechoic cap or structure that covers the bony surface, and this should not be confused with fluid. This is the cartilage or the hyaline cartilage that is on the surface of the bone. Okay. The other joint moving medially is the humeral-ulnar joint, where you can see the coronoid process of the ulna and also the trochlea, and again, that characteristic anechoic hyaline cartilage, not to be confused with fluid. We scan superiorly and change the depth. We are looking at a deeper structure. We can move the focus onto that structure. Here we can see a fossa or indentation in the distal humerus, and here we are looking at the anterior fat pad, and this is what is displaced on the radiographs when there is a joint effusion in this area. And you can scan lateral to medial, looking in this recess, and also turn transverse. So turn a transducer 90 degrees. And here again, you will see the fat pad sitting in this fossa. And then scanning distally, you can also see the cartilage on the surface of the distal humerus here. Okay, now looking for the distal biceps tendon, there are a couple of ways you can do that. One way is you can start a little bit more proximal and slide the transducer down in the transverse axis and watch the biceps muscles converging to form the biceps tendon. Let me adjust the depth here and focus on the structure being imaged. Okay, and you can see again the muscle fibers converging to form the tendon. Here is the tendon. The tendon is hyperechoic and ovoid. You can see the fibers packed into the tendon. And if you happen to not see the tendon, perhaps you're experiencing anisotropy, so you would like to rock the transducer to make sure that you see the bright tendon. And you can scan down distal to follow the tendon. I'm adjusting the depth again as it comes to its insertion. And again, you will be losing echogenicity due to anisotropy. But once you localize that tendon, you can turn your transducer to the long axis of the tendon. And again, adjusting again the focus. You can follow the tendon down to its insertion on the radial tuberosity. And at the insertion, you may see the tendon fanning out. The other thing you want to do is to heel toe your transducer. That means to push your transducer down because you would like to orient it along the axis of the tendon and bring it parallel to the beam. On the screen here, you can see without reorienting it, you lose echogenicity due to anisotropy. But as we heel toe the transducer, you can see you can bring out the parallel echogenic lines that make up or that represent the collagen fibrils in the tendon. Another way to look for the distal biceps tendon is to use the bony landmarks. So here we are again over the radiocapitellar joint in long axis. Okay, here again, we see the characteristic squared off shape of the radial head. We can slide the transducer down, see the radial neck and the radial tuberosity. Slide a little bit more medial to bring the tendon in view. The other thing is that the tendon inserts on the medial aspect of the radius. So you can instruct your patient to hypersupinate their arm or point their thumb down. Here we see the tendon coming into view. If you can't find the tendon this way, you can slide a little bit more medially. Look for the brachial artery, and the tendon is just lateral to that. So you can find the brachial artery, use it as a landmark, then slide your transducer laterally and point or angle laterally to bring that tendon into view and show it as it inserts on the radial tuberosity. If you're experiencing anisotropy or see anisotropy at this level, you would heel toe to the transducer again to bring the fibers parallel or perpendicular to the sound beam. And again, you want to look at any structure in both short axis and long axis. So here I am turning the transducer with the marker at 9 o'clock. There's a little anisotropy here, so you can rock the transducer to make the tendon more echogenic, and then you can follow the tendon towards its musculotendinous junction. Note that the tendon is lateral to the brachial artery, and you follow it cranially till you see the musculotendinous junction. Okay, moving on to the lateral elbow. It's best scanned with the arm pronated. Okay, good. Gel here. Now you want to look for the bony landmarks. Okay, we will be looking for the lateral epicondyle. You want to adjust your depth. Okay. And you see there's a down sloping appearance. Okay, and then you can see the squared off appearance of the radial head. And here we can see the fibers of the common extensor tendon. And if I slide down, I just wanted to show you these are the muscle fibers coming in, more hypoechoic, musculotendinous junction. And then as you slide up, you see the fibers inserting along the lateral epicondyle. Okay. Now, whenever you scan something in long axis, you also want to look at it in short axis. So we will turn the transducer 90 degrees. You want to keep, again, the marker of the transducer towards the right side of the patient. And again, we are looking at the lateral epicondyle, and as we slide distally, we can see the fibers of the common extensor tendon. So we would like to look at the tendon in both the short axis and long axis plane. Now, remember again about anisotropy in tendons. So make sure that you rock the transducer to differentiate between pathology and just decreased signal or decreased echogenicity related to anisotropy. Okay. Moving back, here we go again. Here we are more proximally. Here is the tendon coming in, the lateral epicondyle. I'm going to turn 90 degrees. I'm going to make sure that the marker is at the 12 o'clock position or more superficial or cranial. So we know that this is cranial or the more proximal portion of the joint. We are going down inferior or caudal or distal part. Here is the joint line. Here is the common extensor tendon. And here are the parallel fibers as they are coming in toward their insertion. Look and note that the bony surface is smooth. And as we angle more anteriorly, we will be looking at the radial collateral ligament, which goes across the joint. I just want to point out that sometimes it is difficult to separate it from the common extensor tendon. Sometimes you may see a demarcation, but it is the more anterior structure that comes across the joint. Okay. Next, we're going to move on to the medial part of the elbow. So again, we can have the arm, let's get just flat, with the palm up. You want to palpate the bony landmark, which is the medial epicondyle. Again, keeping the transducer marker pointing at 12 o'clock or towards the patient's head, and in palpating the bony landmark. You can start by placing the transducer adjacent to the landmark and then readjusting on the screen. Okay, now you want to make sure that the depth is set right, that you have the structures you're imaging included in view, and that the focus is on the structure you are imaging. So for now, we will be looking at the common flexor tendon, which is a little bit more anterior. As you can see, the collagen fibers are coming in and inserting on the medial epicondyle. Also note that this tendon is shorter than the common extensor tendon, so we see more of the muscle in view. Here are the flexor muscles. Okay, and coming in, here is a myotendinous junction. And here we see the fibers of the common flexor tendon inserting on the medial epicondyle. Make sure that you scan the entire extent of the tendon. So you want to sweep anterior to posterior. You also want to make sure that you scan the tendon in short axis. So you would rotate the transducer 90 degrees, make sure the marker is to the patient's right. And starting at the most proximal aspect and looking at the medial epicondyle, you can sweep to image other portions or more distal portions of the tendon. You want to adjust your depth so you get better detail of the tendon. And as we slide down, you are now at the muscle as we have passed the musculotendinous junction. Moving back into long axis view, and again adjusting our depth, we will now look at the ulnar collateral ligament, which is a deeper structure. So we want to move the focus down and slide the transducer more posterior, and now you can see the ulnar collateral ligament as it stretches across the joint. And here's the joint space, here's the ulna, here's the distal humerus. And here we see the ulnar collateral ligament extending across that joint. We can also perform a stress maneuver on that joint and see if this joint space will open in the setting of a complete ligament tear. And one way is to exert pressure to produce more valgus stress on the joint. So we can put our arm across this part of the joint and try to open up the joint by pushing out on the patient's hand while keeping the transducer in the joint. And you can see that the joint space does not widen excessively in this case. And you can see that the ulnar collateral ligament stretches across that joint. Last thing, we want to look at the ulnar nerve. So we could bend the patient at the elbow and locate the two bony landmarks. We have the medial epicondyle and the olecranon process. And we would like to place our transducer across those two bony landmarks. Okay, now here on the screen, we have the olecranon process. We have the medial epicondyle, and there's a groove here in which sits the ulnar nerve. Now the nerve is hypoechoic and ovoid. And see how, if you can appreciate that honeycomb appearance as I'm scanning this nerve distally. I'm going to come back again in the cubital tunnel and scan the nerve more proximally. Here it is in the posterior compartment of the arm. You also want to scan the nerve in long axis, so you again would rotate your transducer. Here you can see the nerve with the hypoechoic fascicles. Adjust your focus. Okay, but then you can slide your transducer to image other portions of the nerve. One other thing to test for is for ulnar nerve subluxation. So again, you place your transducer across your two bony landmarks. You look at the nerve here. Now, if the nerve is subluxing or dislocating, it will slide up and hook over the medial epicondyle and even move anteriorly in severe cases. So you can flex and extend at the elbow while scanning and see if the ulnar nerve will sublux or dislocate. And you can see that her nerve sits nicely in that groove and does not sublux. Okay. Last, we will look at the posterior elbow. You can have the patient place their arm across their abdomen. You have the elbow flexed about 90 degrees. You might want to put a little platform to move the elbow off the table for ease of scanning. And we will look at the triceps tendon first. The marker, again, should be towards the head of the patient. And the insertion, we know, is on the olecranon process. So we can place the transducer right over the expected location of the tendon. And here again, you can see the tendon in long axis with nice parallel echogenic fibers. Here's the triceps muscle. So here we're looking at the musculotendinous junction. And as we slide down, the tendon fibers angle to its insertion. So there is some anisotropy at the insertion. One way to address that is to have the patient bend their arm in 45 degrees flexion, and now you can see the insertion quite nicely. You can see the smooth cortex and the insertion of the fibers onto the olecranon, but also the fibers are now perpendicular to the beam, and we have eliminated the anisotropy. Now we can look at the posterior recess for joint effusions, and since this is a deeper structure, we're going to adjust the depth, and we want to focus on this deeper structure. Okay, move your arm back. Okay, so here we are looking at the posterior fat pad, and this is what is displaced when there is a joint effusion. So if we were looking for effusion, we would see fluid and we would see the fat pad displaced outwardly. One more thing to look at in the posterior elbow is the olecranon bursa. And that is actually located more distal to the apex of the olecranon. So instead of scanning posterior, you will really be hooking your transducer around distal to the apex. on the screen. I've now hooked around my transducer, and this is a potential space. So unless it is filled with fluid, you should not see it. Now, because it's very superficial, we will decrease our depth again, and we will focus on a superficial location. Okay, now this is the olecranon, and this is the triceps inserting. So we've now come around distal to the expected location of the olecranon bursa. Now, one pitfall would be if the bursa had a little bit amount of fluid, you would compress the fluid and not see it distending the bursa. So one way to avoid that pitfall is to use more gel and to press very lightly. So here you see that gel interface. Here we see the olecranon, and this is the subcutaneous tissues, and the bursa would sit here. So if there was a small amount of fluid in the bursa, by scanning with this technique, you would not compress the fluid and efface the bursa. Okay, we're going to start scanning the volar aspect of the wrist. Okay. Again, you'd like to use a linear transducer, as high frequency as you've got. Some gel here. I'm going to keep the marker at 9 o'clock when you're doing the transverse axis. Okay. So here I am scanning. This is the carpal tunnel. This is the bony floor of the tunnel. And in it, you see the flexor tendons, the digital flexor tendons, and you can have your patient wiggle their fingers. You see the tendons moving here. And sitting on top of the tendons is the median nerve. Now note that the median nerve is less echogenic or hypoechoic to the tendons. Also, you should be oriented perpendicular to the tendons in order to get this nice bright appearance. If you rock your transducer, you can see that with anisotropy, the echogenicity drops in the tendons. Another portion of the carpal tunnel you'd like to see is the flexor retinaculum, which is the roof. Okay, now looking back at the median nerve, when you scan the median nerve, it has that typical sonographic appearance of honeycomb in short axis, and that is because of the hypoechoic fascicles surrounded by hyperechoic connective tissue, the epineurium and the perineurium. And that honeycomb appearance is maintained as you scan proximally to see the median nerve dive in between the forearm flexor muscles. And in long axis, I'm going to turn now and move so that the marker is at 12 o'clock. And I'm looking at the nerve in long axis. The median nerve is hypoechoic in comparison to the flexor tendon. I'm going to slide down to look at the median nerve. Here again, you can see it is hypoechoic because of the hypoechoic fascicles in comparison to the hyperechoic tendon just deep to it. So this is the median nerve in long axis. I'm going to turn back again into the transverse axis. Again, here we go. We're looking at the median nerve, the flexor tendons. And there are a couple of structures to not confuse with the median nerve. First is the flexor carpi radialis tendon. Now more proximal in the forearm, it lies adjacent to the median nerve, which you can see why it can be confused for the median nerve. But again, if you rock your transducer, you can see that there is more anisotropy exhibited by a tendon than by a nerve. And as we slide towards the carpal tunnel, you can see that the flexor carpi radialis comes to lie at a more lateral location than the median nerve. And there's another structure which is very thin in this patient, which is the palmaris longus tendon. It's this pancake structure right here. I'm going to move the focus that area. You can even decrease the depth. You can see that it's very thin slip sitting just superficial to the median nerve. Now here's another scanning tip. If you are scanning something that is very superficial, you can heap up the gel and scan with a very light hand. Now here in the image you can see here is the gel interface, and here is that palmaris longus tendon, and here's the median nerve. Now in this patient, it's a very thin tendon, but in some patients it can be thicker, and you can see how it could be confused also from the median nerve, which lies just deep to this tendon. Okay, so here's the median nerve, here's the palmaris longus, and here's the flexor carpi radialis. Okay, another structure in the volar wrist is the ulnar nerve, which lies in Guyon's canal. Now a good landmark would be the pisiform, as the ulnar nerve lies in between the pisiform and the ulnar artery. If you want to confirm whether this is an artery, you could use Doppler. But here we are looking at the ulnar nerve, and the ulnar nerve also has that typical honeycomb appearance in short axis. Okay, and you always want to scan the structure proximal. Here it is. I'm going to move the focus down to that. See it better. And then as you scan distal, you can see the ulnar nerve here. Okay, and also you want to scan it in long axis, so you can rotate your transducer till your marker is at 12 o'clock. Try to keep the ulnar nerve in view. Here's the ulnar nerve as it hooks over the hook of the hamate. Okay, and that's the ulnar nerve in long axis. We've got it back here in short axis. You can see the pulsating ulnar artery next to it. Okay. So just a quick review. We have the median nerve. We have the flexor tendons in the carpal tunnel, with the flexor retinaculum, the flexor carpi radialis, the palmaris, and then we've got the ulnar nerve next to the ulnar artery. Okay, moving on, we're going to look at the ulnar views and the dorsal views of the wrist, so we can have the patient pronate their arm. I'm going to try to look here. Lots of gel. Marker is at 9 o'clock. Okay. Now a good landmark to start with for the dorsal views is Lister's tubercle. And that is this bony prominence right here over the distal radius, okay? And sitting just lateral to this, or the left of the screen in this case, is the extensor pollicis longus tendon. And that is the third of 6 dorsal compartments in the wrist. Now it's a good reason, the good idea to start at this level, because distal to this, the extensor pollicis longus tendon will cross over the other tendons and will no longer be the third when you start counting. It will no longer be the third compartment. So let's start at Lister's tubercle. And this is the third compartment, which is extensor pollicis longus. Now I'm going to move over medially to look at the second compartment, which is the extensor carpi radialis brevis and extensor carpi radialis longus, these two tendons. And then the first compartment, which is affected when you have dequervains tenosynovitis. And this is the extensor pollicis brevis and the abductor pollicis longus tendons. Okay, and a good way to remember that, aside from just looking at the book, is if you start with extensor pollicis longus, This is going to be longus, brevis, longus, brevis, and longus, okay? So just in review, first compartment, second compartment, extensor carpi radialis tendons, longus and brevis, extensor pollicis longus, this is the third compartment, adjacent to Lister's tubercle. Then we have the fourth compartment, which are the extensor digitorum tendons and the extensor indicis, or the pointer finger. You can even have your patient wiggle their pointer finger or lift their pointer finger to see you're in that compartment. The fifth compartment is extensor digiti minimi, or the pinky. You can wiggle your pinky. See, that's the fifth compartment. And then the sixth compartment holds the extensor carpi ulnaris tendon. Okay, you can follow that. Okay, so sixth compartment, extensor carpi ulnaris, extensor digiti minimi, or the pinky. Fourth compartment, which is the biggest one, contains the extensor digitorum tendons and the extensor indicis. At the level of Lister's tubercle, we've got extensor pollicis longus in the third compartment, just proximal to where it crosses over the second compartment, and that is the extensor carpi radialis brevis and longus. And then the first compartment, which is the extensor pollicis brevis and the abductor pollicis longus tendons. Okay, and any tendon that you examine, you'd like to examine in short axis, and then you would also want to turn your transducer with the marker pointing superior or cranial to look at the long axis views of those tendons. Now swinging over laterally back to the extensor carpi ulnaris tendon. When you want to look at the TFC, the triangular fibular cartilage, fibrocartilage, is deep to the extensor carpi ulnaris tendon. Let me just change the depth here. Move the focus down. And you can even adjust your gain. Okay, and the TFC is this structure that is right up against the distal ulna, not to be confused with the meniscal homologue. And there is a deeper portion of this that dives down to attach to the radius. Turn up the gain so you can see a little better. And here we're looking at the TFCC. The extensor carpi ulnaris tendon is just superficial of this. Got the meniscal homologue. This is the distal ulna. Another thing you can look at is the scapholunate ligament, which is a U-shaped structure, but the dorsal component is the one most involved with injuries. And so one way to look for it is to follow the distal radius till you cross over the radiocarpal joint to find the scaphoid and the lunate. And the ligament that bridges these two is the dorsal portion of the scapholunate ligament. So you can adjust your settings either by using a special button on your unit or tweaking the gain to your liking. Moving on to the fingers, to look at the flexor tendons. Okay, we start in long axis. I'm just going to use the third finger as an example here. Now, when you're scanning something that is not a flat surface, you want to make sure you use a lot of gel to improve contact between the transducer and that structure. Good. You keep the marker again cranial or proximal in the patient. Okay, now here we are looking on the screen. These are the flexor tendons of the middle finger, okay, and there are two. There is a superficial and a deep flexor tendon. And you don't often see the definition between the two. But at this level, I'm at the level of the metacarpophalangeal joint, which is this joint right here. This is the proximal phalanx, metacarpal. You have two tendons. Now, one way to separate the two tendons is to selectively flex the finger at the DIP joint. It's right here. And you can see that only the deep tendon is sliding, with the superficial tendon remaining stationary. When you flex at the proximal joint, both tendons will slide. This is one way to study tendon tracking in cases of trigger finger or when there is scarring. Okay. So we're looking at the superficial and the deep flexor tendon. And we can follow these tendons distally. Here now we are at the proximal interphalangeal joint, and then at the distal interphalangeal joint, where you can see the deep tendon extending and inserting at the base of the distal phalanx. I'm just going to move the focus up so you can see it a little better. But here's that tendon. Now, if you notice, the tendon isn't uniformly hyperechoic, and that is because at this level, the tendon is perpendicular to the beam, and then you can see that it dives down, and then as it comes back again perpendicular to the beam, again you see it becoming more hyperechoic. So that is all a function of anisotropy. Okay, moving back up, you want to scan the tendon in long axis, but again, you want to scan it in short axis. Now, a nice thing about the finger tendons is that you can use the adjacent tendons as comparison. Okay, but here we are again. These are the flexor tendons of the middle finger, and we have a superficial and a deep flexor tendon. You can sort of see that cleft here between the two. And as I'm scanning and sliding the transducer distally, the superficial tendon will bifurcate into two portions, and they will come to lie on the side of the deep flexor tendon and eventually insert in the middle phalanx. The deep flexor tendon will continue on to insert on the base of the distal phalanx, right here. Another thing to notice is that there are pulleys which secure the tendons to the underlying bone. Here in this long axis view, the A1 pulley is typically at the level of the metacarpal head, and then the A2 pulley spans this wider area or longer area to secure the flexor tendons to the proximal phalanx. And you can see that it doesn't run the length of the proximal phalanx, which is why this tendon is lifted up a little bit or not directly abutting the underlying bone. Now, you don't typically see the pulleys when there is no pathology, and it's certainly difficult to see here. You might see a little portion of it here. But when you turn the transducer to see the transverse or short axis view, you see this hypoechoic halo around the flexor tendons. And that should not be confused with fluid. That is the A1 pulley at the level of the metacarpal head. Okay, so I just slid right across the joint here, and now we are looking at the A2 pulley, which is thinner in this patient, around the tendons, and I want you to appreciate when you don't see pulley and when there is pulley, because there's not pulley throughout the entire length of the flexor tendons. So here we see a halo where there is pulley, and then we lose that halo in the portions where there is no pulley. One other structure to point out is a volar plate, which is a connective tissue that's sitting deep to the tendon here, and that should not be confused with synovium or synovial hypertrophy. Last thing, if you want to look at the ulnar collateral ligament, which is involved in the thumb with gamekeeper's thumb. Okay, I'm just going to wipe off the gel here. Now, one thing you can do is you can have your patient grab the roll so that their thumb is opened up. So just, drape their hand across the roll like that. And you want to be scanning like a coronal plane of the thumb. Okay, you look for the metacarpal phalangeal joint of the thumb. Just open up your thumb there. And to know you're in the right location, you want to be looking for a concavity in the bone so that you can find the bridging ulnar collateral ligament, because as you know, the ligaments connect bone to bone. Okay, and in this case, I'm going to again decrease my depth to get a better picture. I might try to adjust the focus. And I also want to increase or decrease the gain to improve the picture. Okay, see how the bony surface changes as you reorient your transducer. Okay, so for the hip, it's a little bit different than the other joints because the hip is deeper in the body. And so, unlike the other joints, you might want to start with a curved transducer. In this case, I've got a curved 5 megahertz. And to start out, you want to be scanning the hip in a sagittal oblique orientation. Okay, adjust your depth. And we see here on the image, we've got the superior acetabulum. We've got the labrum, the femoral head, and the femoral neck. And the joint capsule extends down, all the way down as far as the femoral neck, and doubles back. So you don't want to confuse this for fluid in the joint. You need to be aware that the synovial lining can be at least 2 to 3 millimeters in thickness. And so in total, you may have up to 6 millimeters of capsule that you don't want to confuse for fluid in front of the joint. But knowing that the capsule extends this far caudal or distal will remind you that fluid will collect in this location when you are looking for a joint effusion. Then you turn transverse, and you can again see the femoral head. And then a little bit more cephalad to that, we are seeing the iliopsoas tendon in transverse, surrounded by the iliopsoas muscle here, the iliacus. And you can scan that tendon in transverse. You can also turn on it to see it in long view right here. But if you plan to do an intervention, if you want to inject into the iliopsoas bursa, this would be a good view. You can come in from lateral to medial approach as the bursa sits and communicates just deep to the tendon. We don't see it right now because it's not distended with fluid. Okay, moving up, we're looking at the anterior inferior iliac spine, and this is where the rectus femoris originates. And I'm going to switch to a linear transducer so we can see it a little better. Now, you can use a 12 or a 9 megahertz transducer. Here we've got a 9 megahertz. So again, make use of your presets on your machine. I'm choosing MSK General in this case. Again, you can start out in a sagittal oblique orientation, adjust your depth. If you have widescreen capability, that might help. Okay. So again, you're looking at the superior acetabulum, the labrum, the femoral head. I'm going to move my focus down. Now you can see with a higher frequency transducer, and if you reorient so that the capsule is perpendicular to the beam, you can see that it is not as hypoechoic as it looked with a curved transducer. So this is the capsule. Okay, now I'm moving transverse. Here we have the iliopsoas tendon again, as I showed you earlier, and here we're looking at the anterior inferior iliac spine, the origin of the rectus femoris. Okay, so here's the tendon, and if you keep scanning distally, you can see it becoming muscle. And then you can also scan the tendon in long axis and show it as it originates from the spine. Okay, now in examining the lateral hip, we have the patient lie with the opposite side down, okay, so that the trochanteric region, which we're examining, is now up. You can use a linear transducer for this. It's a more superficial structure. Okay, now one way to look for the greater trochanter is to first find the femur, or the femoral cortex, which is a curved structure, and scan cephalad until you see the apex of the trochanter. Okay, and there, the anterior portion, the lateral portion, and then there's a more curved looking posterior portion, or posterior facet. Okay, now in lateral, you can see that it's a relatively flat surface. Okay, and the greater trochanteric bursa lies against this. You actually don't see it right now because it is not distended with fluid, and fluid distension is certainly one of the criteria or one of the findings you would look for when you're assessing for greater trochanteric bursitis. But going back to the transverse view, I'm just going to start here with the anterior facet. This is where the gluteus minimus inserts, and you can see it right here. If you want to confirm that you're looking at a tendon, you might want to rock the transducer to look for anisotropy. And then, of course, just like with any tendon, you want to evaluate that in long axis and in short axis. So here's the long axis view of the gluteus minimus tendon. You see the gluteus muscle right here, okay? And then scanning more posteriorly, we're looking at the gluteus medius tendon insertion. Okay, and we'll also see part of the iliotibial band right up here. Okay, so when you want to assess the iliotibial band, you can look at it in long axis and also in short axis. And this is one of the structures that you want to look at during a dynamic scan if you're assessing for snapping hip. You can see what the iliotibial band, if that's the cause of the snapping. But this is the short axis view. And then we're looking at the long axis view right here. Okay, now moving on to the medial part of the hip examination, we're going to look at 3 structures, again utilizing a linear transducer. Okay. I start transverse here and localize the rectus abdominis muscles. We have the 2 rectus muscles here on the screen. You can confirm even, you can look in long axis and see that the fibers are oriented longitudinally. Okay, here's the other muscle. Okay, now moving back to a transverse plane. Here are the 2 bellies of the rectus abdominis muscle, and I'm going to slide the transducer distal, following the muscles and following them to their insertion on the pubis. Now here is a transverse view of the pubis and pubic symphysis, which is right here. Okay, and you can see portions of the rectus muscle just above that. Now turning in long axis, you can follow the muscle fibers and see it at the insertion onto the superior pubis. And you can, in a similar fashion, evaluate the other rectus insertion onto the superior pubis. Okay, another part of the medial hip scan is to look at the medial thigh muscles. I'm just going to adjust my depth here. Okay, so in this scan we see portions of the gracilis, the adductor longus and adductor brevis. Okay, here we are, longus, brevis, gracilis. But the adductor longus inserts on the inferior pubis, so you can follow that muscle as it's forming a tendon. Just adjust my depth here. But you can see here is the inferior pubis, and here is the insertion of the adductor longus onto the inferior pubis. And here's the tendon in long axis. Okay, now for the posterior hip, there are 2 structures that we will be looking at. Again, using a linear transducer, in this case a 12 megahertz transducer. I'm localizing the ischial tuberosity. Okay, and this is the site, the origin of the hamstring tendons, or the tendons of the hamstring muscles. So you can see them in transverse here, okay, and follow them down to the muscle. And you also want to image in long axis. To look at the tendon, look for any thickening or any calcification or any irregularity to the surface at the insertion. Now the other structure, the sciatic nerve, can sometimes be difficult to localize proximally depending on your patient or on the equipment that you're using. So I find it easier to look for the sciatic nerve where it is most superficial. And here I'm starting in the posterior knee or the popliteal fossa. And you can see the sciatic nerve, the fascicular pattern surrounded by the hypoechoic muscle. And one other landmark that you can use is the artery, as it tends to be adjacent to the artery at this level. And you can find that if you want to use your color Doppler function. Okay, but here, let me just adjust my focus. We're looking at the sciatic nerve in transverse. And again, you see the hypo to anechoic fascicles surrounded by the hyperechoic perineural tissue. And then you can scan cephalad or more proximal following the sciatic nerve to look for any pathology. I'm going a little deeper here. And with any structure, of course, you want to scan in the transverse plane and also in the long axis. And here you can see the fascicular pattern of the sciatic nerve, and you can see the hypo to anechoic fascicles surrounded by the more hyperechoic perineural tissue. Just like when imaging the elbow, it's useful to image the knee in compartments or divide the knee into 4 compartments. So for this part, we'll be doing the anterior part of the knee first. And for this, we have the patient supine. You may want to put a roll or a pillow or a towel to have the knee partly flexed and have the patient relaxed. Second, be using a linear 12 megahertz transducer with the presets on the machine set to general musculoskeletal. Okay. We're going to start with the quadriceps tendon, which extends down and inserts onto the patella. So you locate the patella and put your transducer just cranial to the patella. Okay, we're going to adjust the depth here, and you can see we are looking at the quadriceps tendon in long axis. Down here in the deepest part of the image, we are looking at the distal femur anterior cortex. And if you notice, there is a hypoechoic or anechoic cleft here, which is separating the prefemoral fat pad from the suprapatellar fat pad. And when you see this cleft widen, or if you see fluid in this space, that may indicate a joint effusion. Also note you see a little bit of the distal femoral cartilage, which is not to be mistaken for a fluid or a joint effusion. Okay, now here again, going back to the quadriceps tendon, if you are looking at this structure, if you want to, you can adjust the depth, get more detail. You can also move the focus onto the quadriceps tendon. So we are looking at the quadriceps tendon in long axis as it inserts onto the superior pole of the patella. You see that the bony cortex is smooth. And you want to sweep from side to side to see the entire tendon. And you also want to scan cranially as you get towards the musculotendinous junction. Make sure that your gain is not set too high. Okay. Now, anytime you image a structure in long axis, you also want to image it in short axis. So you will turn your transducer with the marker to the patient's right. And again, you're going to look at the quadriceps tendon cranially at the musculotendinous junction. And then towards the patella, you will scan it. You'll see it's a wide structure, and you scan it until its insertion onto the patella. If you want to look at the distal femoral cartilage, you can have the patient completely flex their knee, and most patients can do this, and place your probe at the apex and locate cartilage on the surface of the distal femur. Now you can see here, cartilage is hypo to anechoic. You don't want to confuse this for fluid, but you can scan and slide your transducer distal to proximal or proximal to distal to look for any cartilage defects or asymmetry or thinning of the cartilage, or you can look for calcium deposits in the cartilage if you think the patient has, let's say, CPPD. But this is certainly one good way to look at the distal femoral cartilage. Going back again, we're going to look at the patellar tendon. We can have the knee partially flexed, and you can slide the transducer along the inferior pole of the patella and look at the insertion of the patellar tendon onto the tibia. Now, because this is not always a flat surface, you may want to fill that in with gel so that you maintain contact. And here you can see the patellar tendon extending from the inferior pole of the patella towards its insertion on the proximal tibia. Now, deep to the patellar tendon is fat. This is called Hoffa's fat. And there are regional bursa in this area. You can have superficial and deep bursa. And one thing to point out is that when you are looking at very superficial structures, if you are scanning with a heavy hand, you may compress bursa or distended bursa that are in that area. So you might want to heap up the gel and scan with a light hand. See how there you can actually see the gel interface here. And so if there are any superficial bursa, you might not compress them and obliterate them from view. Okay. Now the patellar tendon is a wide structure, so when you're scanning it, you should sweep from medial to lateral. As you can see, as I'm sweeping, we see tendon throughout. And you also want to image this in the transverse plane. And here you can appreciate that it is a flat and wide band. And so if you're only scanning in this location in long axis, you may miss pathology that is in this location. So you want to make sure that you image it in two views, but also that you sweep from side to side. And you move from the most cranial aspect, and you keep scanning it till the most caudal aspect at its insertion. Now moving on to the lateral knee, we have your patient lie in the decubitus position with the part that you are scanning up. You can also make them more comfortable by either putting a pillow or a rolled up towel between their knees, okay, and have their legs partly flexed. I'm going to start with the iliotibial band. So you can palpate for Gerdy's tubercle where the iliotibial band inserts and place your transducer just cranial or superior to that structure. Let me just adjust my depth here. Now you can see the iliotibial band extending down over the distal femur and inserting onto the tibia, and it fans out a little bit at its insertion. You can see it has that linear, compact architecture that you expect to see with tendons. Okay, now sometimes you can have pathology at the insertion, but you should again scan the entire tendon in long axis first towards the musculotendinous junction, because some of the times the pathology can occur as it snaps over or as it slides over the distal femur. So you may want to look just deep to the iliotibial band more cranially, as there can be a distended bursa in this location when patients have iliotibial bursitis. Okay, so this is the iliotibial band, and you want to scan that again all the way toward the musculotendinous junction, and also scan it in transverse as it hooks over the distal femur and then towards its insertion onto Gerdy's tubercle. Okay, so that's the iliotibial band. Then you can slide back, or you can palpate for the fibular head, and there are two structures that insert onto the fibular head. The more anterior one is the lateral collateral ligament or the fibular collateral ligament, and then the more posterior one will be the biceps tendon. So I'm looking first at the more posterior one, and you can see it here as it inserts onto the fibular head. It fans out at its insertion, and then you can see its short and linear compact structure and the musculotendinous junction more cranially. Okay, and sometimes you can actually see that tendon depending on your patient. Then you slide or pivot your transducer more anterior. Okay, so again, I'm here on the biceps tendon, and you can pivot more anterior to bring out the fibular collateral ligament or the lateral collateral ligament into view. You can see a groove more cranially, which is the groove for the popliteus tendon. And you can see that tendon here. You can confirm that by rocking your transducer and bringing out anisotropy in that tendon. Okay, and also at this level, you can see the lateral meniscus. So here we are looking at the joint. Here's a distal femur. Here's a tibia, and the lateral meniscus sits in between as an echogenic structure. And then again, when you're scanning these tendons, you always want to scan in long axis, and then you also want to turn your transducer and look for any enlargement or surrounding fluid or decreased echogenicity in the short axis. Okay, now moving on to the medial knee. You can either have the patient on their side, on the bed or on the stretcher, or you can have a towel rolled up just to prop up the knee. Okay. Adequate amounts of gel. Okay, so first things first, you'll see a linear structure with parallel echogenic lines, and you'll see it extending over the medial meniscus. So here we are looking at the medial meniscus, which is an echogenic triangular structure. Okay, and while ultrasound is not the best for looking at the entire meniscus, you can certainly see more superficial portions of the meniscus or more peripheral portions of the meniscus. So here we are looking at peripheral portion of the medial meniscus. We don't see the deepest parts of the meniscus. And overlying that is a linear structure which extends from the distal femur and extends over the medial meniscus. And you want to make sure that you examine the entire structure because it actually extends down lower than you think. And you can see this band extending all the way down past the proximal tibia, and that is the medial collateral ligament. And here we are again in the medial collateral ligament here. Now you don't always see the retinaculum as a separate structure, but it is a thin structure that overlies this entire complex. And again, you want to scan anterior to posterior and looking for absence of the architecture or decreased echogenicity or perhaps some irregularity signifying that there is surrounding fluid. But when there is an abnormality of the medial collateral ligament, that would imply that there are some other abnormalities in the knee. Now to look for the pes anserine tendons and the bursa. These are usually very fine tendons that are harder to see. I find that it's sometimes useful to scan and look for them in the transverse plane. They are thin tendons, which include the semitendinosus, the gracilis and sartorius tendons, and you can see them as pancake-like or flat, thin tendons that are inserting on the anterior medial knee or anterior medial tibia. When you find them in short axis, you can follow them all the way cranially. If you're not sure, you can compare it to the other side to see if they are enlarged or decrease in echogenicity, but also the patient should be complaining of tenderness when you're scanning this area if there is pathology. But once you localize those tendons, then you can turn to image them in long axis and just note the plane of the transducer as the tendons come down and insert onto the anterior medial tibia. Now, sometimes you may only see a little bit of thickening at the insertion, or you may see a bursitis, which is a fluid around or deep to the tendons at their insertion. When they're normal, they can be very difficult to see. Okay, and that's the medial knee. And last, we'll be scanning the posterior knee. Okay, usually I start by localizing by looking for the lateral and medial heads of the gastrocnemius muscle. Now they usually don't fit all in one view, so I look for this cleft in between the heads, and if you sweep over or slide your transducer laterally, you're looking at the lateral head of the gastrocnemius. Here's that cleft in between the two, and then now I'm sliding over medially to look at the medial head of the gastrocnemius. And if you slide even more medially to look for the medial border of the medial head of the gastrocnemius muscle, you can slide up Move your focus to that area. You can also adjust your depth. But if you slide up along that medial border, you will see the semimembranosus tendon and the medial head of the gastrocnemius in one view, and a Baker cyst or a popliteal cyst, which is a distended semimembranosus gastrocnemius bursa, will be arising from this location. The neck will be here, right between the medial head of the gastrocnemius and the semimembranosus tendon. And you can confirm that you're looking at a tendon by rocking your transducer. You see that anisotropy. But this is where a Baker cyst will be arising. And if you can find that connection, then you can make the diagnosis that you are looking at a Baker cyst. Because as we know, not all cystic structures in the back of the knee are Baker cysts, and you would always like to confirm the origin to be able to make that diagnosis. In long axis, it would be sitting on top, usually, of the medial head of the gastrocnemius, which is this muscle over here. Okay, so that's another thing you can look at, and you'd be looking at it in long and short axis. Now, you could also look at the semimembranosus tendon, which I said you would confirm by looking for anisotropy. And when you locate that, you can turn on that and look at the tendon in long axis as well. So here is that fibrillar structure that we know represents tendons, and you can see the fine parallel echogenic lines in the semimembranosus tendon. Okay, next, going back to the medial head of the gastrocnemius, sometimes patients may present with pain in the posterior calf, and that pain could be medial. And if you look and follow, let me just adjust my depth here. Focus down. But if you follow the medial head of the gastrocnemius, more gel here, towards its insertion into the tendon, here we are at the myotendinous junction, and I'm turning in long axis. So here we are, this is the medial head of the gastrocnemius. We are looking at the soleus muscle here. And here where you see a beak forming, this is the myotendinous junction between the medial head of the gastrocnemius as it forms into the Achilles tendon. And you can get tears in this location, or medial gastrocnemius tears. So here you would look for a disruption of the normal pennate structure of the muscle. You may see irregularity here, or loss of this beak, or you could see fluid or a hematoma in this location. Now sometimes patients will have pain in this location, and the medial head of the gastrocnemius will look normal. But you might see a fluid collection in between the medial head of the gastrocnemius and the soleus muscle. And in that case, you might be looking at a plantaris tendon rupture. And in fact, here is the intact plantaris tendon lying in between the gastrocnemius and the soleus muscles. So if the fluid collection is localized to this location, you might be looking at a plantaris rupture. If you have a problem in the muscle, you might be looking at a medial gastrocnemius tear. And the only other thing to point out is that oftentimes you have both diagnoses, so you might see both. Okay, now back in transverse, here is the gastrocnemius, here is the soleus muscle. Here we are looking at the tibia, and you may see a fluid collection sandwiched by these two muscles. Again, that would imply that you are looking at a plantaris tendon rupture. So this is the medial head of the gastrocnemius. Again, sliding laterally. Here we are looking at the lateral head of the gastrocnemius, and then back to the medial and more towards the popliteal fossa. We have the semimembranosus tendon, and we have the location of the neck of a Baker cyst or a semimembranosus gastrocnemius bursa. And that's the posterior knee. And now we'll be imaging the ankle. And again, like all other musculoskeletal studies, for superficial structures, you would like to use a linear transducer. This is a 17 megahertz transducer, so I've moved up in megahertz because we're looking at very superficial structures, and this is for superior resolution. For the anterior ankle, we'd like to have the patient supine with their foot flat on the table or on the stretcher. And then, just like with the knee and with the elbow, we will be imaging in 4 compartments, and we'll be starting with the anterior ankle now. Now there are 3 tendons that you look for in the anterior ankle. We are looking for, from medial to lateral, we are looking at the anterior tibialis tendon, extensor hallucis tendon, and the extensor digitorum longus tendon. Okay, so starting out with the anterior tibialis, let me adjust my depth here. Okay, and this is the most medial structure. Now, if you have trouble finding this, you can always have the patient lift or dorsiflex their foot, and you can actually see the anterior tibialis tendon lifted. You can actually feel it here in the anterior medial ankle. Okay, so that's the anterior tibialis tendon here. And again, you want to follow it in transverse all the way cranial towards the muscle, which is here. Here we see the muscle coming into view. Okay, then you follow it again in transverse all the way towards insertion on the medial cuneiform and base of first metatarsal. So here we are in long axis, looking at the anterior tibialis tendon. It's a very superficial structure. Notice again the fibrillar structure with these fine parallel echogenic lines. See that the tendon is uniform in thickness throughout. There's no loss of architecture or abnormal echogenicity throughout that tendon. Back to the transverse plane. If you go to the next lateral tendon to this, we are looking at the extensor hallucis tendon. And again, you want to follow this all the way towards its insertion. It's a very fine structure. Follow it also transverse as you see the muscle coming in. Here's the muscle coming in here. And again, you also want to look at this in long axis. It's a thinner tendon in the anterior tibialis, but here you can see the fine parallel echogenic lines of the extensor hallucis tendon. Now more laterally, we are going to be looking at the extensor digitorum longus tendon. So more proximally, it looks like it is composed of 1 tendon, but as you scan distally, you will see that this will branch out into 4 tendons supplying the 4 toes. So here is that extensor digitorum longus tendon. And again, you want to scan that in transverse and in long axis. And you can see the same architecture and the same appearance as other tendons. Now, sandwiched in between the extensor digitorum and the extensor hallucis is a neurovascular bundle. If you're scanning too hard, you may obliterate the vein, but you do see here there is an artery. You can confirm that with color Doppler. So there's the artery, and there's the vein compressing. But here we are looking at the anterior tibial artery and the deep perineal nerve, which is right next to or part of this neurovascular bundle. One other thing is you can look at the anterior recess of the ankle. That is best seen starting with a long view. You want the marker of the transducer pointing up, or 12 o'clock. You want to adjust your depth because this is a deeper location. But here you can see the distal tibia and the talar dome. You can see that the talar dome has a cartilage cap because this is part of the joint. Make sure that your gain is not too high. But in this location, you may see an outpouching when there is fluid in this recess. You don't want to confuse the cartilage over the talar dome for fluid. And that's the anterior ankle. Okay, moving on to the lateral ankle. We will look at the lateral ankle ligaments and also the peroneal tendons. So first is you want to palpate for the lateral malleolus, and you can put your transducer in transverse plane with the marker pointing to your left, the patient's right, or to the 9 o'clock position, and you want it anterior to the lateral malleolus, okay, and you put the transducer across from the fibula to the tibia, and that's where you will find the tibial fibular ligament, which extends across and serves as a stabilizer. Okay, now to look for the talofibular ligament, you keep your transducer on the lateral malleolus and you just swing it down towards the talus, and that's where you can bring the talofibular ligament into view. Now, one way to bring it out is to have the patient plantar flex or point down. See, now here we can see the ligament stretched across. We see that it is intact. We see nice, smooth, bony surfaces at their attachment sites. But this is one way that you can bring the ligament into view. You can also have the patient plantar flex to see if there is instability across that joint or widening across that joint space. Now to look at the peroneal tendons, again, in using the lateral malleolus as your landmark, you position the transducer posterior to the malleolus, and you should see in transverse axis two tendons, the peroneus brevis, which is against the bone or the deeper tendon, and the peroneus longus tendon, which is more superficial or farther away from the bone. And as with all the other tendons, you want to scan this in transverse or short axis all the way cranially as you see the muscle and the musculotendinous junction coming into view. And then you would also like to scan it distally towards their insertion. Now, the peroneal tendons sit against the lateral malleolus, and then they hook down and change their axis as you go distal to the malleolus. So once you go distal to the malleolus, you want to stay transverse to the tendons. Here they are in view, and follow them towards their insertion. The brevis is more anterior, and it stays anterior as it inserts onto the base of the fifth metatarsal. So here we see it coming into view here in long axis, and that's one place where you would like to scan that tendon. You can have an insertional tendinopathy or perhaps an avulsion when there is injury of this tendon. The longus is more posterior, and you can see it here as it dives down and hooks around under the foot towards the first metatarsal. And you can also scan that and turn and see it in long axis. So here we see it. It is decreased in echogenicity due to anisotropy as it is diving down towards a deeper part of the ankle. Okay, moving back, the calcaneofibular ligament, as its name implies, extends from the calcaneus to the fibula. And you can see it as a sling underneath the peroneal tendons. So here we have the peroneal tendons. The ligament is not straight, and therefore there is some anisotropy when you're trying to image it. So you can have the patient dorsiflex. And as you can see, the ligament now is stretched out, and you can see it just deep to the peroneal tendons. And again, the ligament has a similar appearance to tendons. You see these fine, compact, parallel echogenic lines. Here we see that the ligament appears hypoechoic because of some anisotropy in that ligament. But you can reorient the transducer to see that the ligament is intact, and you can see that it is diving deep to the peroneal tendons as you extend from the fibula to the calcaneus. Now, one of the nice things about ultrasound, one of the benefits of ultrasound is its dynamic capabilities. And so in scanning the ankle, particularly the lateral ankle, you can assess for perineal tendon subluxation. And you can do this by first localizing the perineal tendons. Here we can see them again, just opposed against the lateral malleolus. And with perineal tendon subluxation, the brevis tendon may sublux anteriorly over the lateral malleolus. So what you can do is, while looking at these tendons and keeping them in view, you can have the patient do the maneuver that can elicit the pathology. So you can have the patient either rotate their ankle, so just rotate, and you can watch the tendons and see that they remain well seated in their location and not sublux or dislocate over the lateral malleolus. Good. Another thing you can do is, while looking at the anterior talofibular ligament, you can have the patient dorsi and plantar flex and see if the joint space is widened. This is especially useful when you're assessing for a full thickness rupture or instability in the joint, and you can look for joint space widening as you have the patient plantar flex and see this anterior talofibular ligament. Okay, now we're going to look at the medial ankle. And there are 3 tendons to look at in the medial ankle. First, again, locate a bony landmark. For this, it would be the medial malleolus. Okay, and we will put our transducer posterior to that. The marker will be 9 o'clock position. Okay, and we're going to be looking for 3 tendons. Okay, now some people use the mnemonic Tom, Dick, and Very Nervous Harry. So Tom is the most anterior tendon, and that is the posterior tibialis tendon. It is larger than the adjacent flexor digitorum longus, D for Dick, Tom and Dick here. Okay, and these two are next to each other. The posterior tibialis tendon is also closely opposed to the medial malleolus. So following what we've done for all the other tendons, you want to keep this tendon in transverse view and scan all the way towards the musculotendinous junction. You can adjust your depth and your gain to get a good look at that tendon, and you follow it in transverse plane all the way to the muscle. Follow it back, transverse. Now, when you're scanning a structure that is not flat, you want to put more gel, and you want to scan all the way till its insertion onto the navicular. Okay, now keeping, again, transverse, you also want to scan the tendon in long axis, okay? And again, you want to appreciate the fine fibrillar structure of the tendon. You want to see if there's any fluid surrounding the tendon or any loss of architecture. Same thing for the flexor digitorum longus. It's not as common to see pathology involving this tendon, but if you needed to look for it, this tendon is the next tendon over, next to the posterior tibialis tendon, okay? And again, if you need to scan that tendon, you want to scan it transverse, all the way from cranial to caudal, and also in long axis to look for any abnormal appearance or fluid surrounding the tendon. I'm going to get back to the neurovascular bundle, which is and very nervous in the mnemonic. And for now, look at the flexor hallucis longus tendon, which is H for Harry. And it's a little bit removed from the other 2 medial ankle tendons. If you're not sure if you can see it, you can either look for anisotropy by rocking the transducer, or you can move the patient's great toe, if she has a great toe. It's pretty great. And you can flex it and see the tendon moving. Okay, now again, you want to follow this tendon as it moves through fibroosseous tunnel here, which will be related to the tarsal tunnel, and you want to follow that all the way towards as distal as possible. See if there's any fluid surrounding the tendon. You can see this tendon lying in this groove here, and follow the tendon all the way also in transverse up towards the muscular tendinous junction. Here we see the muscle. And you also want to look at that tendon in long axis, so you can see it right here. Okay? Moving back to transverse, you can see between the flexor hallucis longus tendon and the flexor digitorum longus tendon, we have the neurovascular bundle. Okay? And you can see as part of this bundle is the tibial nerve. So every now and then when you're looking for pathology that could be impinging on the tibial nerve, especially distally at the level of the tarsal tunnel down here, you're keeping the tibial nerve into view. This is where you might want to look for ganglia or other masses or structures that may be impinging on the tibial nerve. And oftentimes when there is a nerve entrapment, before you even see a narrowing of the nerve, you may see an abnormal appearance to the nerve. So again, you'd be looking for loss of the normal architecture or decreased echogenicity of this nerve, the loss of the echogenic perineurium and epineurium, or you would look for abnormal thickening of the nerve. But this is the tibial nerve right here in long axis. So you'd want to be looking at the nerve in long and short axis. Now last, if you're looking in a patient who you suspect has a medial ankle sprain, you will look at the deltoid ligament, and that is best seen scanning in the coronal plane. And you would place your transducer with the marker just inferior to the medial malleolus, okay? And you would look for a ligament extending from the medial malleolus, hanging off of that, and look for various attachments in the ankle. Here we're looking at an attachment on the sustentaculum. You can also see that it is deep to the posterior tibialis tendon. So you're looking for these fibers that are extending inferiorly from the medial malleolus. And if there is abnormality, again, you would lose echogenicity and lose architecture in that ligament. Okay, now last, we'll be looking at the posterior ankle, and the best position for this is to have the patient prone with their foot extending off the stretcher. This allows you to image and have the patient flex, plantar flex, and dorsiflex to look at the Achilles tendon. And we'll have the patient relaxed for now, and we're going to look at the Achilles tendon. Okay, you want to place the transducer just superior to the heel or the insertion of the Achilles tendon on the calcaneus. We're going to be looking at the Achilles tendon in long axis. Here we are looking at the tendon. It's a very superficial structure. You can see these fine parallel echogenic lines. We can scan the tendon all the way to its insertion onto the calcaneus. Now I just want to alert you that as the tendon fibers dive down, you will see some anisotropy. You want to make sure to bring the fibers perpendicular to the beam to remove the anisotropy and make sure that there is no pathology at the insertion. You can see that the cortex is nice and smooth at the insertion. Okay, now we will slide cranially to follow the Achilles tendon towards the musculotendinous junction. Here again you see that we are maintaining the architecture of the tendon. You can see that it is relatively parallel or uniform in its thickness. And here we are as we get to the tendon, and you can see the musculotendinous junction right here. You also want to scan the tendon in transverse. So here we are. Here we see the muscle. Here we see the tendon. If you're not sure, you can rock the transducer again to bring up the anisotropy, but this is the tendon, which is a wide, flat band. And as it is formed, you see, it becomes an ovoid structure. Now, because we are looking at a very small surface, you tend to get dropout because there's nothing up against the transducer from lateral to medial. But you want to maintain contact with that tendon as you scan towards its insertion onto the calcaneus. Okay? Here we are looking at Kager's fat pad, and there are some bursa in this area that you can image. There's a small bursa located between the Achilles tendon and the calcaneus called the retrocalcaneal bursa, and this can sometimes distend with fluid. And there's also an even more superficial bursa, the retroachilles bursa, the superficial Achilles bursa. And again, if you're scanning a superficial structure, you may not want to scan with a heavy hand because you could obliterate the bursa and miss it during your scan. So one way around this is to heap up the gel and scan with a very light hand. You can see here's some gel, and that you'd see that a very superficial bursa. You can see there may be a little bit of fluid here, and you can see that as I press, I'm obliterating that bursa. So in order to see it, you would like to have a light hand when scanning and heap up the gel in order to see the superficial or retroachilles bursa. Okay, coming around to look at the plantar fascia, we swing around and we look for a linear structure that is inserting onto the calcaneus, but now we are looking on the plantar aspect of the foot. Let me adjust my focus. And my gain. And now you can see there is a linear structure that has a similar appearance to a tendon that is extending towards and inserting onto the base of the calcaneus right here. And this is the plantar fascia. So this is where we look for plantar fasciitis right at the insertion. You may see an enthesophyte or a bony projection arising from the calcaneus. We don't see one here. You can have the patient dorsiflex to straighten out the plantar fascia. Okay? And again, you want to image this in long axis. You can also appreciate in short axis that this is a wide structure. And so if you are imaging on the wrong portion of the plantar fascia, you may miss pathology. And in following the plantar fascia towards the more distal part of the foot, you can see it's very superficial. Change the depth and focus on that structure. But here you can see the plantar fascia as we extend towards the more distal foot. And this is medially, this is where you can look for plantar fibromatosis, which is focal hypoechoic thickening along the plantar fascia. Lastly, when you're looking in the interdigital spaces to look for an interdigital neuroma or a Morton's neuroma, you can have the patient sitting on the stretcher with their foot up, okay, and you want to be scanning from the plantar aspect of the foot. Again, you would use a linear transducer. You might want to use not so high a megahertz. This is a 12 megahertz transducer. And you are going to be looking at the spaces in between the metatarsal heads. Okay, so here I've got that showing in view here. This is the 5th metatarsal head, 4th, 3rd, 2nd, and we don't have the 1st in view. Now we're looking at the intermetatarsal spaces, and what you're looking for is some nice clear fat. Morton's neuroma would show as a well-defined hypoechoic structure occupying the space. Okay, now oftentimes you can't really see well in these spaces, so one thing you can do is while you're scanning with one hand, you can press from the other side, from the top of the foot, and this does a couple of things. One, it pushes the metatarsal heads away from each other, but it also brings the intermetatarsal structures closer to the transducer. So you can see that there's nothing sitting in this space right here. You see the fat in the intermetatarsal space. If you saw a hypoechoic structure in that area, you may think that you may consider a Morton's neuroma, or sometimes an intermetatarsal burst that can fill with fluid, but you would be able to compress that with compression. Once you localize whether there is something in that area, then you would again turn your transducer in long axis to see if that structure persists. And again, if you are looking at a Morton's neuroma, then you would try to trace the nerve into and out of that structure if you had a Morton's neuroma. But that is the way to scan the interdigital spaces.